Hello everyone, my name's Ken Sutherland. I work for Canon Medical and I'm based in Scotland. First of all, I'm very sorry I can't be with you today, but hopefully we can still have a useful session and I hope you find my presentation interesting. I'd also like to thank the organisers for the chance to talk to you today. I'm going to talk to you a little bit about how AI can impact the whole flow of image acquisition through to diagnosis. We're going to try and look at that and see what are the opportunities and what are the risks and what can we do to try and reduce and mitigate some of these risks. But first of all, I want to start with a quotation. I'm going to start with a quotation from Professor Geoffrey Hinton. So Jeff Hinton is a Google Fellow. He's also Professor of AI at Toronto University in Canada. And what he said about 5 years ago now, just over 5 years ago, he said, if you work as a radiologist, you're like the coyote that's already over the edge of the cliff. And you don't realize that radiologists are going to be redundant because deep learning is going to replace them in 5 to 10 years' time. Now, when he said this, it was very controversial, and perhaps that's part of the reason why he said it. But I had the privilege to meet Professor Hinton in Edinburgh at the Royal Society of Edinburgh just over 2 years ago now. And we had a really good chat because I said, look, I'm kind of in this industry. I'm really interested in what you're saying and I'd like to understand it. So we had a real good conversation. We also shared a glass of wine, which you can't see in the selfie photograph I've got here, but we had a really useful conversation. We didn't quite agree, and I want to explain to you how we don't agree. But we're going to go through that as we go through step by step. We still, as I say, had a good conversation, and I think I understand where he was really coming from when he made this quite bold prediction over 5 years ago now. But before I dive into that, I'd like to say a little bit about the company I work for and just give you a little bit of context to my presentation. So I work for Canon Medical based in Scotland. So obviously Canon's a large multinational company, Japanese-owned company that works in a number of different sectors, including medical devices and medical imaging. I work for an organisation based in Edinburgh in Scotland, the beautiful city of Edinburgh, as you can see here in this picture. And the organisation's existed for over 25 years now. We started off purely medical imaging, taking acquired image data sets and converting them into 3D for visualization, but we've moved on into helping users to interpret these data sets. And we've gained a core competency in AI during that process and amassed a significant portfolio of patents and intellectual property. We've also worked very closely with collaborators in the UK, in Scotland, and all across Europe. Principally in the UK, we've worked with NHS clinical colleagues. We've also worked with some of our fantastic academic organisations in the UK, with support from both Scottish and UK government to help us innovate for the future. So as an organisation, what are we interested in? So I'm just going to give you a mission statement here. So the image is an illustration of how we see the clinical expert in the future. We see that person accessing lots of different data and using all of these different data sets together to form the optimal decision and create the optimal treatment choice for that individual patient. So our mission as an organisation is to support our parent company, Canon Medical, to develop and deploy augmented systems. And that's critical. I'm going to pause there for a second. We're not interested in replacing radiologists. What we are interested in doing is augmenting them and enabling them and other clinical experts to be even more efficient and effective. And our way of doing that is to apply highly automated full clinical pathway support across the complete hospital enterprise by using proven technology to aggregate, visualize, compare, and interpret subtle indicators within healthcare data sets. So the goal is to try and help and enable clinicians to make the diagnosis as early as possible. Obviously, earlier you intervene, the better outcomes for everybody, including the provider, the payer, the patient, and the clinical expert. So that's our mission as an organisation. But let's dive into this pathway for imaging. If you think about when you visit a doctor, and you get a scan, this is the sort of process you follow. So a consultant, a clinical expert, makes the decision that the scan, some diagnostic is necessary. The scan is then acquired, it's visualized, some analysis is done, then that's interpreted, and then probably a report and a decision as part of that process and a result. And then perhaps you go around this loop several times. That's the overall loop we're going to consider. First of all, I want to zoom in on the first part, which is all around about the images. and the visualization and analysis, and through into interpretation. And I wanting to show, first of all, how AI can impact this whole chain of events, but also how it's not only AI that has a benefit and an opportunity within this pathway. So let's think about visualization for a second, and I'm showing you some images that really talk to the history of our business. So these are genuine images of acquired data, and when you show these to lay people, most often they'll think they're looking at illustrations, or maybe they're looking at 3D printed photographs of 3D printed models of the human body, but they're not. They're looking at genuine 3D visualizations of live patients acquired through imaging. And this global illumination is incredibly lifelike, realistic, and useful for clinical experts to understand what's going on, but also to communicate with patients. And that's increasingly important as we look at healthcare, in communicating and engaging the patient and their family, their friends, their support group in their own care and the future of their ailment or whatever it is they've got wrong with them, then that's really important. So we believe that the imaging process is really important part of that. And here's another couple of examples. Again, we're showing here the global illumination applied to ultrasound for fetal imaging. And again, we're showing some other CT imaging here on the right, where we're showing global illumination. Again, creating an image that's very easy to explain to the patient, or in the case of the ultrasound imaging, very easy to explain to the parents what's going on with their unborn child, and to allow them to start to engage and maybe bond with that child while it's still in the womb. So I think there's some fantastic opportunities when we look at these style of imaging. And there are other examples of this. And so, for example, we can now take these images and we can slice and dice them in many different ways. We can literally create arbitrary planes through these 3D data sets and produce wholly novel ways of looking at the human body, but also through segmentation and identifying individual structures, we can remove them or deprioritize them or illuminate some and dim out others, as you're seeing within the 3D lung data set, where we're showing the airways. And again, key opportunity here is probably not so much about diagnosis, it's more about interpretation and understanding and explanation to patients and perhaps other members of the care team. When they see the actual pathology in situ, they can understand what's actually going on and what the best route of care is for that individual patient. So that's just visualization though. The next step, as we mentioned in our pathway, is analysis. And these are two examples of some of the analysis that we're now able to perform. So I'm not showing the left hand is actually a video showing one of the heart valves opening and closing in a 3D video, obviously acquired in vivo. And what you're able to do with that, you can then look and see how the valve is opening and closing and what the aberrations are and whether that person requires valve replacement surgery. On the right-hand side, you're seeing what's now quite a conventional CT analysis, coronary analysis, where we've identified the heart, we've removed everything around the heart, orientated the heart correctly, we've identified the individual blood vessels around the heart, and then we've tracked down through the individual blood vessels and identified the amount of calcium and the amount of plaques, and we've generated some ratios and measurements. Now, again, must emphasize, this is just about accumulating information. We're only providing a guide for the human to be able to understand what's going on and then make the clinical choice that they require to make. So I think it's a really interesting opportunity to think about this as a step that we're going to add to the other steps as we go through the process. So let's talk about image acquisition. We're very lucky in Canon Medicals. We've got some fantastic work that we've done in applying artificial intelligence to the actual image acquisition process. We did this initially in CT imaging, and we did it as part of the reconstruction process, where we convert the acquired waveform into a human readable image data set that radiologists and other experts can review. And we did this through quite an interesting process of training. So just to explain the process, so this diagram shows two parts. The top is how you train the network. So obviously, as I'm sure we all know, we need to train the network on lots and lots of different examples of things and not things, or whatever it might be that we're trying to get it to do. And the network then creates a generic pattern that then uses for the future. Now, what we've done here is essentially to try and train the network to understand what noisy images are when we're talking about radiology imaging, and try and explain to the network, or trying to get the network to learn how to convert these noisy images and filter them essentially into a better quality image. So we give it lots of examples of what's good and what's bad, and we get it to learn how to denoise essentially, and how to accentuate the important medical information, the diagnostic information, and how to filter out and deprioritize the noise that exists within these images. We can then apply it for real to low dose images, which obviously low dose CT acquisitions are noisier, they're inherently noisier because there's less signal and more noise as we wind down the dosage of ionizing radiation. But still we can take these images and convert them into high quality output. And that's what you're showing in the bottom part of this diagram. We're seeing that the model that's trained at the top is then extracted from the training environment, used within the product to take live images as they come in as part of the reconstruction process and remove the extraneous noise and create high quality output. We can then couple that piece of technology to our global illumination. And what you're seeing here is exactly that. So we've, again, using CT images, we've taken high quality images acquired using our ACE reconstruction and then done the global illumination 3D visualization to allow you to see the power when we put the two pieces of technology together. And again, I use this just as an illustration to point out the fact that we're going to use these different building blocks, some of which already exist within conventional imaging and conventional approach to imaging, and we're going to ally it to the opportunities that AI gives us. But the critical part of this is we're going to do this in quite an intelligent way. We really are going to try and apply it where it works and not where it doesn't work. But also we're going to be realistic about what we expect it to achieve by applying it in this way. So that's just one example of what we're doing. Now, to broaden our opportunities, we've started working with the University of Edinburgh. We created a Centre of Excellence for AI for Imaging and Healthcare Data at the organisation I'm responsible for in Edinburgh, Canon Medical Research Europe. And we chose to do this in Scotland for one really strong reason. And the really strong reason was that we have an academic reputation for AI in Scotland that's probably second to maybe 2 or 3 other places in the world. We're privileged to be working with the University of Edinburgh. University of Edinburgh is top 20 university in the world with expertise, particularly in informatics, engineering, and AI, and artificial intelligence. And in fact, Professor Hinton, who I mentioned earlier on, who's now AI Google Fellow and Professor of AI in Toronto, did his PhD at the University of Edinburgh and learned his trade by working with these colleagues. So we've now formed a strategic relationship, and Canon Medical now sponsors a chair of healthcare AI at the University of Edinburgh, and the current incumbent is Professor Sutherland, who's shown in this image, second on the right in this image, standing next to myself. So a really exciting opportunity for us to take the different components of AI and the different potential of emerging AI, which is a professor of AI he's in the middle of understanding, and apply that to these different component parts of the process. And we're going to talk through some of these as we go through. This is one area where we can apply AI, obviously, is to imaging. So you'll be aware of many other systems that other people have talked about. I'm going to talk about probably something nobody else has talked to you about, which is mesothelioma. So mesothelioma is a very specific cancer. It's incurable, and it affects people who've been exposed to asbestos. It creates this very unusual lesion that's around the lung, and unfortunately, it causes these people to die. Ultimately, there's no treatment and there's no real, at the moment, there is some investigation of potential drugs that might help with this process. Now, because it relates to exposure of asbestos, the population of people who get mesothelioma is very specific. Mainly, they're men, and mainly the men who've worked within heavy industry where they've been exposed to asbestos, particularly things, for example, like shipbuilding. So there's actually a cluster of mesothelioma cases in Glasgow in Scotland, which is on the west coast of Scotland, and traditionally is a centre of heavy industry. Now, As mentioned, obviously, we're aware now of the risk of asbestos, but not everybody, sadly, in the world is. And we're now at the stage where some of the equipment that was manufactured maybe decades ago is now being dismantled. And sometimes that's been done in parts of the world where their safety precautions around the handling of asbestos is maybe not as mature as it is in other parts of the world. And so we're seeing novel cases of mesothelioma now occurring, unfortunately, in almost a second wave. So it is interesting. It's interesting from a research perspective, but it's also still tragic for these people who've developed it late in life, having been exposed potentially decades previously. And what we've done here in collaboration with the Professor Kevin Blythe at the University of Glasgow, working with an NGD student of ours, Owen, who's shown here, we created a network that can identify and differentiate between people who do and don't have mesothelioma, but also give an assessment of the overall size and the volume of this very unusually shaped lesion. What's the value of that? Well, the value of that potential is as we start and as our clinical colleagues start and pharmaceutical companies start to develop potential treatments for cancer, then it can be applied to patients in this case, and by scanning them and doing automated measurements of their lesions, we can see whether their lesions whether the treatment's been effective to try and reduce the scale of the cancer that they've got. Now, what's really interesting, actually, it's really quite interesting for us, was when we talked about this, and there's a publication now that has now been issued for this project. Got a lot of press interest, both locally but also nationally, partly because it's just incredibly interesting to people at the moment that AI is available to help and support clinicians with disorders like mesothelioma, but also because generally there's an awareness, certainly here in the UK, but also in other parts of the world, that our clinical experts are under tremendous pressure, particularly now, probably now more than ever in their lifetimes, or even in the lifetimes of modern medicine, that our clinical colleagues are under such pressure, and the opportunities that something like AI can bring as an aid to their efficiency and their effectiveness as clinical experts is really important. So we were quite surprised, very pleasantly surprised, by the level of interest that this particular innovation got. And we're excited by the opportunities to hopefully use it to support colleagues like Professor Blythe as they start to look for potential cures or opportunities for treatment. So, talking about AI, though, one of the lessons we learned from a project like mesothelioma and others is something that other people have talked about. And I've stolen this picture from another person. And they've shown, speaking about AI training and the way we teach the network, many people think the diagram on the left is true, that it's all about just some software work or some great work by some smart data scientists. But in reality, the bottom pie chart is much more realistic. We're probably, 70% of the effort is finding and verifying and annotating the necessary data that we need to train the network. Because to learn, as we all know, for networks to create generic solutions to problems, we need to give them lots and lots and lots of examples, probably of annotated data sets that allows the network to create a generic model of what that disorder looks like and what normal looks like, so that it can differentiate between the two, or it can measure, or whatever it is we're challenging the network to do. So the bottom right hand picture here is much more realistic in terms of acquiring data and annotating it and stuff like that. Now, fortunately, this maybe isn't as big a problem as it might have been only a few years ago, because we're starting to make inroads into this area. One of the ones we're looking at as a company, and this is published at work this year, relatively recent by my team in Edinburgh, in collaboration with Professor Savartas. We've worked closely on the idea of extracting information from radiology reports and understanding if we can use this to select images that we can then use to train the network. So in this case, we're doing a project looking at stroke, and we're trying to find images that have stroke lesions in them. And so we've gone through radiology reports, automatically finding the data that we need to find, finding the relevant phrases within that report, and then being able to reference back to the images. So instead of asking a clinical colleague or even a very junior researcher to go through thousands of images and find me all the images showing X maybe we can get the network to do some of that work for us. So that's a really exciting opportunity. Another exciting opportunity we've created is an environment in Scotland where we can work with clinical colleagues to do this much more effectively. And we've created, along with partners, what's called the Industrial Centre for AI Research and Digital Diagnostics, or ICARD for short. And ICARD's a collaboration with the NHS, with some academic partners and some other companies funded by Innovate UK, which is part of the UK government. And what we've been able to do under this project is to create what we call the Safe Haven AI Training Platform, or SHAPE, we call it for short. And we've created that because of the model that exists within the UK. And it's not unique to the UK, but it is specific here. And generally what happens is that data is held regionally, and it's held within an NHS safe haven. So the data is held at individual sites, probably for a group of hospitals and not just one individual hospital, but a number of different hospitals in one region. And a substantial amount of data is held within their secure environment. Now, to do our AI training, one model would be for us to ask to extract all of that data and either create a public large data lake, as people call them, or maybe we would do it privately and we'd want to access that data. We'd pay for access to the data and we'd pull it all back into our own system. However, that model really doesn't scale. Our belief is it's much more effective for us and others to go to the data. And so with the ICARD project, we've created infrastructure where innovators like ourselves or others can go to these individual sites. And this is currently installed in 2 sites in Scotland, in Glasgow and Aberdeen. And innovators and other companies, including the companies listed here, so Bearing Research and Canon Medical, are partners of this project, and they can go to these sites and access data using the SHAPE model. And the key thing is we're not removing that data from that safe environment. We're doing the training in that safe environment. And all we remove from that is the trained model. And that's what's illustrated in this diagram here. So we take the trained model out of the blue box on the left, and we use it in anger in what we call the AI evaluation cockpit to validate it and make sure it's effective. And that's a much more scalable model, because as probably we all know, if we only train AI models on, say, Scottish men like me, it'll only work for Scottish men like me, and that's very limiting. Brilliant for me, but not so good for everybody else, perhaps. So what we need to be able to do to create real effective AI algorithms, we need to train them on super diverse populations all over the world. Fortunately, there's a technology available called federated learning that allows us to create models based on the data at each individual site. And then we can aggregate the models together rather than the data. Now, there's some sophisticated science that makes this work. You might be thinking, oh, how on earth does that work? Well, it's not obvious, so there's some sophisticated work that other people have done, but this is the opportunity, and this is what allows us to scale and come up with effective generic solutions for AI. So we're now able to do training in Scotland, maybe in Russia, maybe in Japan, maybe in Brazil or whatever, and by doing it in many different sites around the world, and aggregating the models together and merging these models together, we can create a generic solution. So using a number of techniques now, we're eating into this data availability problem. The other thing we're doing is we are really concentrating on workflow. And Canon Medical, we've got a piece of technology called the automation platform, and we've started deploying this to do zero-click analysis in advance. And again, critically, in the diagram we show at the bottom there, we're simplifying the workflow for the clinical expert or the radiologist, but we're still entirely dependent on merging together technology with the human to make it work in an effective way. So there's a real focus on workflow. And we're not the only company, we're not the only organization to identify this, but it's really very, very important. A piece of AI on its own is almost useless unless it fits within an effective workflow for care for the patient. So my reality, a slight modification to the diagram I showed you earlier on, if we come up a level, I think there's really 3 components to effective AI training and deployment within a healthcare system. There's good training, as we've just talked about. There's good validation, where it's validated at maybe cross sites and things like that. And then there's effective workflow integration and validation. And just to emphasize that point, a little cautionary tale based on a publication that just came out quite recently in the British Medical Journal, the BMJ, as it's called, where they did a bit of a meta study really of AI algorithms applied to breast cancer. And their conclusions were quite negative. Let's dip into the conclusions box here. And they've said that the benefit's unclear. AI systems are not sufficiently specific to replace radiologists' double reading in screening programs. Promising results found in smaller studies were not replicated in larger studies. So there's some significant concern, and many people have commented on this paper. However, it's worth reading into the data and understanding it. And there are a couple of caveats that I would say that are significant. So the first caveat is they're looking back in time. So obviously the technology they used is no longer state of the art. It may be out of date, and there may be limitations, and there may be things we understand now about how to create good AI algorithms that weren't in place when these algorithms were created. But also, they also absolutely make the point about workflow and the fact that we must be looking at how AI is applied in real clinical practice and not just in the laboratory for us to decide whether it's effective or not. And I think that's a valuable observation and something that we should all stick to when we think about rolling out AI for real clinical practice. So I guess a possible quick checklist would be that you need to have robust data collection and curation. We need to have state-of-the-art AI training. We need to have effective internal and external cross-validation of results. And then we need to have that clinical validation and evaluation happening within a real clinical workflow. So I think it's a really interesting situation, and hopefully you can see that what I'm interested in doing is enabling clinical experts to use AI as most effectively as possible. So I don't believe that AI is going to replace radiologists anytime soon, or maybe even in my lifetime, but it will enable them to work more effectively. Obviously, there's lots of pitfalls. We believe that we can overcome these pitfalls with good science and good partnerships. And then finally, just about this workflow integration thing. That's the only way to make it valuable, and that's the only way it's going to work. Thank you very much for your time, and apologies I can't be with you in person, but thank you very much. Appreciate it. Bye for now.